along with that. So history is the most important thing to achieving great outcomes or data gathering. The first thing I ask the patient after introducing myself is, what's bothering you the most about your vision? Is it driving, nighttime glare, reading? Do you hate the way your glasses look or feel? Patients, I'm sure you've all heard it, I want my 20-year-old eyes back. But expectations do need to be tempered. And we need to find out, is blended vision an option? What's their ocular dominance? Just to really understand their experience, because every patient is very different, as you all know. So let's talk about the young patient category. So we're correcting refractive error. As I said, LASIK and SMILE are the two main options, PRK as well, but that's not my favorite. This can be bilateral same day. It's super effective, preserves natural accommodation, and treats a wide range of myopia and astigmatism. Contraindications are zoster, simplex within a year, and autoimmune disease, as well as severe dry eye. And unrealistic expectations is a big one. EVO ICL is reversible. There's a really wide range of treatment, so it's an amazing game changer for my practice. And you don't really touch the cornea except for the small wound. It's great for non-LASIK candidates and preserves natural accommodation. PRK is kind of the last option for me because it's less predictable. It takes time for the epithelium to heal. The outcomes are the same long term, but it's just patients don't love the view the first week. So I don't love PRK quite as much, but it's an option. We'll talk about that. So a lot of people ask me this question: time out of context for a refractive evaluation. For soft spherical lenses, 1 week, and for a soft toric or extended wears, 2 weeks. Gas perm, 1 month per decade. And a lot of doctors, for the refractive evaluation, the first visit, it's okay to have the contacts in because we'll be obtaining at least 2 other refractions, the pre-op visit and then the day of surgery. So we'd rather them come in wearing the contacts than not have them come in at all because it's a barrier to entry. But you can see the effects here of the toric lenses. So the left side is they're out for 3 days and the right side out for 2 weeks. So it significantly changes that astigmatism pattern from inferior steepening to regular astigmatism. So what is LASIK? So basically we use a femtosecond laser to cut, it's like a knife, we cut the flap with that laser and then lift the flap and ablate the surface of the cornea using an excimer laser. So there's 2 separate lasers we need for this procedure. You can see the left picture is going under the flap and dissecting the plane and then lifting the flap on the right side. LASIK outcomes are excellent. There's some bad press recently from a naysayer who is a retina specialist, and she's just famous for speaking out against LASIK. But you know, there are patients who, of course, have complications, and there's a lot of venues that practice very inexpensive laser or LASIK with no follow-up. Patients will have problems in those settings sometimes, and that's the problem. The LASIK is amazing, and we just have to continue to provide our patients with trust. Outcomes speak volumes. So I think that those of us who are practicing good medicine and good refractive surgery can hopefully spread the word and get the word out from our perspective. So these patients really do great. These are just some images using great slit lamps, which I'll talk about later, just to show you. This is the edge of the LASIK flap. Does my point? Can you guys see the pointer? Does this work? So here's the edge of the LASIK flap right here. Very hard to see, but if we're co-managing, it's important to be able to distinguish that, make sure there's no gutter, no epithelial ingrowth, or flap melts. These are flap stria. They can happen really early on. Microstria usually aren't a problem. It's when there's a mismatch between the flap and the stromal bed underneath. So the flap is basically scrunched up, creating these little folds. And if they're visually significant, they should be ironed out and the flap should be laid back down. So we can do that either at the slit lamp. Here's some pictures from Dan Reinstein's course. He usually takes the patient to the slit lamp immediately the day of surgery, checks the flap, irons out any stria. And you can see here he's doing that at the slit lamp as well, day 1 adjusting in month 1. Epithelial ingrowth, early diagnosis is key. So If you see it, definitely call about it. It's easy to take care of, but you really have to do it quickly. You can also do it delayed, but it's nice to just prevent it from spreading. But basically the treatment, you can do a laser or you can lift the flap, clear out those epithelial cells that have crept under the flap into the interface, and then lay the flap back down. And usually that does the trick. It's not common in primary LASIK, but more common, 1 in 6 post retreatments can typically get epithelial ingrowth. So it's important to counsel the patients. This is DLK, which is inflammation in the flap interface. It's inflammation, not an infection, so treatable with steroids. But early diagnosis is key. This is a bad corneal ulcer and the interface. And this is a dehisced flap. So basically, don't do LASIK on a UFC fighter or someone with a lot of who's very physically active who can get punched in the eye, because these flaps can dehisce years after the LASIK is performed. So but this can be laid back down and smoothed out. It's just something you want to catch early. This is PISC. It's very rare, but important to look for. If the pressure is high, you can get fluid in the interface. So important to, and it's a response to steroids typically. So important to reduce the pressure in these patients. This is a decentered ablation. This is much less common these days with our laser femtosecond flaps. With the microkeratome in the olden days, it was more common to decenter the ablation, but this is what that looks like. You can see this ablation is superior. The center should be right here. And that can give them a lot of aberrations. This is post-LASIK ectasia. We're getting so much better at, deciding who is a candidate for LASIK and identifying early form fruus keratoconus. But this can happen if you operate on someone with too thin corneas or who is predisposed to keratoconus. And then PRK, basically you just remove the epithelium and then ablate the surface, change the shape of the cornea, and put a contact lens on, and then let the epithelium heal. So you can imagine it's not quite as immediately gratifying as LASIK, but it does work really well. This is post-PRK haze, which is a rare complication, but it can happen. So we use mitomycin routinely in PRK patients. So what is SMILE? A lot of people ask me, what is this thing called SMILE? It has such a strange name, and it does. It's small incision lenticular extraction, and it's all over China. It's all over Europe. It's less common here, but it's growing in popularity. It's an amazing procedure. I call it LASIK's cousin. It was approved in 2016. And it just doesn't correct hyperopes, but for myopes and patients with dry eye, it's a great option. I'll show you what that looks like here. So basically, we're creating a small wedge of tissue that we're lasering into the cornea and then removing. So by doing that, we are changing the shape of the cornea and therefore the refractive error. So you can see here, this orange is the bottom of the wedge. And then you do side cuts here, a cap here in green, and then this whole orange wedge we just remove from the eye. There's possibly lower ectasia and dry eye risk, although the studies are somewhat questionable per Dr. Reinstein. He's the world's expert on SMILE. There's no flap, so there's no flap complications. There's more limited applications, and you do need a special Zeiss Visumax laser. But other than that, it's great. Evo, what's the story with Evo? A lot of people are asking as well about this. Evo is a real game changer, like I said before. It's really broadened our ability to help patients with visual correction who weren't candidates with LASIK, but it's becoming more and more a lot of surgeons' first line. So basically, this green here is the Evo ICL. It sits in the sulcus behind the iris and anterior to the lens. And patients 21 to 45 is on the FDA approval, but you can obviously go outside of that if you need to. Refractive error -3 to -20. This is what's so exciting about it, because a lot of patients who can't tamper with the cornea because of the risk of ectasia can have Evo. So it's bringing hope to a lot of patients. It's stable, it's an inert lens. You need to have a deep enough chamber to accept the lens so you don't cause crowding and elevated pressure. And then you, of course, have to look at the corneal health and for angle issues. But this is on the left, you can see the original Visian ICL. Basically, with the Visian ICL, you had to, sorry about that, do a laser peripheral iridotomy in order to not cause angle closure, because this lens is blocking the pupil. So if you put this lens in without a PI, you're causing the pressure to spike. But with the EVO, which has the central port, this is the game changer. And the fluid can go from the anterior chamber behind the lens and cause a little buffer on the anterior capsule. So you're preventing angle closure, preventing anterior capsular cataract. So it's really been a game changer to this lens. And this is the lens going in. It's super easy. It takes 5 minutes. We can do bilateral same day. And it just kind of implant it with a little viscoelastic, and it just sits behind the iris. Possible complications, vault issues, although you'll see the complication rate is extraordinarily low, and rotation of a toric lens. If you size the lens incorrectly, it can rotate if it's kind of moving around in the sulcus. This is the literature. You can see the published literature in the FDA trial. I mean, those numbers are pretty extraordinary with 4,000 patients. Risk of cataract, pupillary block, and pigment dispersions, like almost zero, basically. So the concerns we had with the previous version just aren't there anymore. So a lot of people ask me, what is the vault? This is the normal vault. So you can see there between those two asterisks, I'll go back, between the ICL on the left and the natural crystalline lens on the right. This is the vault. And normal vault is about 500 microns. Shallow vault is here, you can see, I'll move the cursor. And then a high vault is here. So with a high vault, the concerns are that the lens is pushing on the iris and crowding the angle. With the low vault, the concerns are that the lens is just resting on the crystalline lens, and causing cataract. But as you saw, we don't see a lot of issues. They tend to bother us more than they bother the patient. But we do check pressure and check lens position after surgery. So pros and cons: LASIK is fast, bilateral, same day, preserves accommodations, rapid recovery, excellent results. Patients are super happy. EVO is amazing. It's reversible. It's a wide refractive range. The cornea is untouched, and the patients do amazing. The ICL is actually closer to the nodal point of the eye than corneal surgery, so patients really have an excellent quality of vision. So let's talk about midlife patients with the presbyopia conundrum, which I'm just starting to notice with my latent hyperopia. Options for these patients are custom lens replacement is one. Here we remove the natural crystalline lens and replace it with a lens that provides reading. IOL options are blended vision with monofocals or light adjustable, and then multifocal or EDOF. And you can do this bilateral same day. There's very high satisfaction rates. It treats presbyopia. Hyperopes really love it because they can't have an EVO, and it's just excellent for them. They have a very low risk of retinal detachment as well. And why wait? Because our rationale is you're going to get a cataract. You're preventing that from happening, and this is going to last your lifetime. There are some reasons to wait, and I'll go through those, but it's just a great procedure, and it's growing in popularity amongst a lot of the refractive surgeons. So we typically operate on, we usually do these lens replacements, stages 1 and 2 of lens dysfunction, when presbyopia has begun, accommodations decreasing, and the visual quality is kind of on the downslope, but they don't yet have a cataract. Contraindications are refractive instability. You don't want to operate on a moving target. You want the eye to be healthy. The patient has to be motivated. It is expensive. And the greatest risk is retinal detachment. So for the high myopes, definitely get retinal clearance, have a long conversation with them about risks and benefits. This was a study that came out in Sweden, this is from Dan Reinstein, 600 eyes, and he's a fantastic surgeon, great results, but average age was 64. He had 14 retinal detachments, and basically showed that the presence of a PVD is significantly reduces the risk of a retinal detachment from 3.4% to 0.4%. So males are also at a higher risk. They're at disadvantage in this area. So we can look for a PVD on exam and on OCT, but it's one of the go-tos that I always check for. For IOL options, multifocal are fantastic for certain patients. They're diffractive, so they split the light into different focal points and create different points of vision for the patient. They're great for presbyopia correction. They really work. They give the patient great intermediate, close-up, and distance vision. I'll show you the defocus curve in a minute. But the downside is halos around lights. This lens is made with these rings, and that's just where the different diffraction points are. And those rings are usually noticed by the patients around lights at night. And you should definitely check higher order aberrations on either a Galilei or a Pentacam to see what's going on with them before you operate. This is the defocus curve of the Panoptics. So you can see they have amazing vision at distance here, 20/20 or better than 20/20. And then intermediate, they're just shy of 20/20, and very close up, just shy of 20/20. So a really wide range of vision. Here's another way of looking at that. They just see great. This is interesting. So in Europe, Dan Reinstein, who's kind of my refractive idol, he uses the MS39 and Osiris, which have 40,000 points of contact for the wavefront and the whole eye aberrometry. So he can look with so much detail, whereas the Pentacam has 10,000 reference points. So you can really see tons of detail about what's going on with this patient's wavefront. So here you can actually see the rings from the multifocal lens. So pseudo-EDOF lenses are great for distance and intermediate vividity. I call it pseudo-EDOF because it's a refractive lens that basically bends the light into, it basically shortens the distance between the two focal points. So it's just squished together to elongate the point of focus. It's less sharp near, but there's no halos around lights, less issues with glare and halos. It's more forgiving with corneal retinal pathology. So here's the defocus for the Vivity lens. They can see really well intermediate and really well close up, but then small print is not quite as good. And here's the MS39 and Osiris for the Vivity. You can see the central area of higher refraction. So the true EDOFs are, to me, one of the most exciting new developments. They're utilizing corneal spherical aberration to achieve extended depth of field. So these are iHance Pure C, which isn't available yet in the United States, but it will be soon, hopefully. And these here you can see the centrally there's a negative SA of minus 0.65, and peripherally it's plus 0.2. So they're playing around with SA to give you a broader depth of field, and you can just see this really wide defocus curve. So there's less contrast desensitivity with the iHance than the other options. This is light adjustable, which is really super cool. It's basically a monofocal lens, but it does have built-in extended depth of focus through aberrations. And you implant the lens. After surgery, you can customize the patient's outcome. So if the patient wants distance vision, but they had LASIK and they have irregular corneas and you don't really know how they'll end up, you pop the lens in and then see where they end up. And then if there's any residual, you just tweak it. You get 3 treatments with this. It does require a lot of postoperative care from the patient, but it's just a great option. And patients see crystal clear, sharp. The optics are amazing. So for the cataract patients, this is really important to do the lifestyle assessment. It's basically the same IOL options as CLR, but you just want to understand that these patients do have the opacity. They're going to be happy getting that opacity out. So you just have to weed out the patients who won't do well with the multifocal and figure out what their priorities are. Look at their comorbidities. And then there's a trend towards bilateral surgery for these as well in the OBS. So we talked about this a little bit. You want to check for zonular issues and trauma. It's a denser cataract, so sometimes they can take more time than a CLR, but they're basically the same procedure. And there's 1 in 1,000 risk of complication. This is a slit lamp photo from the SL800. You can see these little anterior chamber cells from inflammation, glistenings of a lens. These are just some possible complications. And then posterior capsular opacity, which you can YAG. So I wanted to go through some cases. This for me is kind of the most exciting part, just kind of driving home the decision-making process. So, and we're good on time. So this is a 25-year-old female casino host. And for lifestyle, she enjoys hiking, swimming, biking, very active, no medical history. She comes in saying she wants to be out of her glasses. She doesn't like the look. And she had really bad contact lens hygiene. Current correction, she uses glasses and contacts, and her refraction is stable. She's a -375, -0.5 at 90 on the right, and a -4, -75 at 89 on the left. And she sees great with that refraction. Her topo is normal, thick corneas, and no other findings. So what are her options? I'll give you guys a second to think about that. We've got EVO, custom lens replacement, LASIK, and PRK. So I'm assuming you're all muttering LASIK, which is the answer. So she's a great LASIK candidate, kind of run-of-the-mill, young patient. She can read. She is a -3, -4. You could do EVO in her as well if she has deep enough chambers. That's another option. And EVO actually only goes down to -3 at this point, but they're coming out with a -1, 1.5 soon. So they're expanding, but LASIK is kind of a no-brainer for her. Case 2. So there's a 43-year-old gentleman, MMA fighter. You know where we're going with that. He has a history of hypertension. And his coach says he has to get out of his glasses and contacts for his own good and for his career. So he wants to get out. He's motivated, and he doesn't wear anything now, but he knows he should. His refraction's stable, and he's a -2 in both eyes. And his topography is normal. He has severe dry eye and MGD. Here are the options. I'll give you guys a second to think about that. So I went with Smile. So he is an MMA fighter. You don't want to do a LASIK flap on him at all because they can't wear protective glasses. And he has severe dry eye and SPK. He can't get an EVO because he's a -2 and it only goes to -3. So he is a great Smile candidate, and he's 43. Case 3. So we have a 54-year-old female psychiatrist. She has no past medical or ocular history. Her readers make her look old, she says, and she just started wearing them and just absolutely can't stand them. She has a refractive stability, and her manifest is hyperopic in both eyes with some astigmatism. She has normal topography and normal slit lamp exam. So what are we thinking for her? Her biggest issue is reader. So she hates the reader. She's 54. She's a little old for to start noticing presbyopia, but that's because she has hyperopia, so that's been helping her out. So I would do a clear custom lens replacement for her. Just so you know, people call them RLE, refractive lens exchange, clear lens replacement. It's all the same thing. It's just different terminology. I like CLR because it's kind of like customized. This is a 25-year-old gentleman. He's a mailman. I'm not sure why. I had a patient today who's a mailman. He has keratoconus, status post cross-linking 2 years ago. And he came in because he wants to see better without his glasses. He was told he's not a LASIK candidate. He lost hope, but he heard there's an option that might work. So he's here for an evaluation. He wears contacts and glasses, but hates them. He is a -9, -6 at 90 on the right, and a -1050, -550 at 90 on the left. And he's seeing 20/20 on the right and 20/25 in his more myopic eye, probably a little bit of amblyopia. And here's his topography. He's steep, irregular, but for the most part, centrally, he is regular. He's got an axis that's treatable with some toric correction. So what are our options? I'm assuming you all know where I'm going with this, but after cross-linking, these patients do amazing with EVO. This is pretty much the most, as a cornea specialist, I used to do transplants and that kind of thing, and these patients really were had no hope for vision correction, and now they do. I mean, we can go up to, I had a patient who was a -18, -20, and keratoconic stable, and she is unbelievably happy. So, I mean, these patients just do really great, and they're very grateful. This is a 41-year-old gentleman, attorney. He had LASIK 20 years ago, myopic LASIK. He's here for blurred vision in both eyes. He wears glasses for distance, is not yet presbyopic. And this is kind of an interesting one. He had a recent change in his refraction over the last 3 years and notes the vision is not crisp in either eye, but he is seeing 20/20 with a -1 in the right and a -0.5 in the left. Without correction, I should have put this on here, he was a 20/25 and a 20/20 plus, or sorry, a 20/25 plus. So he's seeing relatively well, but he's noticing blur, and you have to take that seriously as a refractive surgeon. So his topography showed a myopic correction, flat centrally, well-centered ablation, and on exam, you can see a LASIK flap with no PVD on retinal exam. So what are our options? EVO, custom lens replacement, LASIK, and SMILE. This is kind of a tricky one. This is a patient I saw last week. And I asked my colleague, Luke Rebinich, for his opinion, and so I got his second sense as well. So we decided on LASIK only in the left eye. So we made his right eye his reading eye, just left it alone, and of course coached him that eye would still feel blurry for distance. And the left eye corrected his half a diopter of myopia. This is the last case, a 75-year-old male engineer, retired. He has hypertension, arthritis, all sorts of things that come with cataract age. History of LASIK in 2003. He's in for a reduction in vision and difficulty reading in dim light. He wears glasses, but he's not opposed to getting out of them. And his refraction is stable. He's a low myope with some astigmatism, with a lot of glare. And his topography shows LASIK patterns with positive aberrations, as we see with post-LASIK eyes. So on slit lamp, we can see his LASIK flap, 2+ cataracts, as you can see on the right, and 0.5 nerves OU. So our options, EVO, CLR, LASIK, or CEIOL. So that's the choice I would go with. So a light adjustable is really great in post-LASIK patients. They have aberrations, sometimes irregular corneas, and they're motivated. He had LASIK, so that tells us he really doesn't want to wear glasses. He doesn't want us to miss the mark. So if we do light adjustable and give him some blended vision and some extended depth of focus, maybe some mini monovision or blended vision, I think he'll be really delighted. And he's an engineer. These patients are very particular. And actually, I've found they enjoy the process of the light adjustments and like to be involved and engaged and kind of tweak their refraction along with the optometrist or the MD. So it's a good option for them. So this is the whole timeline. I hope it makes a lot more sense now in terms of how to direct certain patients to different types of surgery. It's certainly helpful if the conversation starts in your exam room and the patient comes in somewhat informed because they've had time to kind of mull over their options and make some decisions for themselves, do some research. So the refractive evaluation really starts with you. So that's very helpful when they come in with some knowledge. Obviously, back to the diagnostics, those drive decisions. It's super important to see what's going on with the eye, what's some pathology that we have to deal with and take into account. The refractive pipeline, the fun part is the puzzle of figuring out what to do with a particular patient and how to correct their vision. For me, that's where the fun is, and the surgery. And then the MD-OD communication, cohesive care definitely results in better outcomes. One of the most satisfying parts of this profession for me has been connecting with optometry and industry, and I think it makes for better care all around. So if patients come up and if you're in Vegas and you want to send them over, I love going through these problems, even if it's not for my patient, or you want to text about a patient in Arkansas. I love going through this problem solving process. So I'm happy to help. My number's at the end of the presentation. And just remember, we're transforming how patients see the world in this industry. So hopefully you learned a thing or two. Here is my contact information. Please feel free to reach out. I'm always available and addicted to my cell phone, so I'm around.
What an excellent presentation, Dr. Shore. We did have quite a few questions roll in, so if you're ready, we'll go ahead and get the Q&A started.
Great. Should I stop sharing my screen or what? Or keep it?
If you leave your contact information up, oh, that's perfect. Yeah. That way, if we don't get to all the questions, they can reach out to you because there were quite a few. One that was asked several times is, how is cataract surgery done after EVO?
So, okay, that's a great question. It's super easy is the answer. These lenses come out, they slide out. You do the lens calculations as normal, because the biometry doesn't change with the EVO. Taking these lenses out is super easy. There's no fibrosis, no scarring. You basically go under the iris with a Sinskey hook and a forceps, and you just pop it into the anterior chamber and pull it out. It folds up really like gel, like a contact lens. So it comes right out of the eye, and then you proceed as usual. It's super easy.
Great. And what do you recommend for post-radial keratotomy patients?
Light adjustable. They're tough. They're tough. Light adjustable or just a monofocal lens. Light adjustable is nice because these patients are so unbelievably unpredictable. So it gives us some power back. But I would wait at least a month between treatments. So usually we could treat up to a week between each treatments, and we get 3 treatments. But I would wait 6 weeks, 8 weeks, 2 months between treatments because you really want things to settle down, and you want those incisions to just internal corneal incisions to just kind of settle, because you don't want to treat a moving target. So light adjustable is great.
Another question was, can low vault in ICL cause accommodation issues?
No, it doesn't have an impact on that.
And up to how much cylinder can be done with ICL?
ICL is up to, let me see, I think it's a -6. How do I get back? Hold on. I'm pretty sure it's a -6, but I can look back and let you know.
Mm-hmm.
Keep going while I search for that slide.
Oh, you bet. What's the best IOP measuring device to measure IOP post-refractive surgery?
So that's a good question. Basically, applanation's the gold standard, but as you all know, the baseline will have shifted after surgery. So I always just get a new baseline. I applanate. Some people, there's something called an aura, which is a contactless pressure applanation, or it's a contactless way to measure intraocular pressure. But if you don't have that machine, it's kind of uncommon that doctors have that. I would just get a applanation, and then that's your new baseline, understanding it might shift.
Mm-hmm.
Okay, so we go up to -6 of cell with the EVO.
Thank you very much. There was a question, is EVO an acronym? And if so, what does it stand for?
It's not an acronym. It's the Visian lens, the latest version with the hole in the middle. And as far as I know, it's not an acronym. It's just, I don't know what it stands for. Someone had a sexy name.
Yeah. I think this question may have been referring to an ICL, but it was, how long will an IOL last? 40 years, and then what do you do?
What do you do if it doesn't last, I'm assuming? They last forever unless there's they're in there. They're in there till you pass away, so they outlive us. But if, let's say, I'm assuming, your question is, does the vision change? So things can happen if a patient's 95 years old with pseudoexfoliation and trauma. The zonules can get lax, and that lens can shift out of position. You may need a lens exchange, or to put a Yamane in. But the lens itself lasts. The main problem that can happen with the lenses is the PCO, the opacity on the back surface of the lens, and that's really easily treatable with laser to clean that scruff off. It's epithelial cells from the natural cataract that you remove the cataract, and then those epithelial cells stick around and crawl across the back of the lens. But the lenses are, they're as good as, they're good forever, like diamonds.
Mm-hmm. Another question was, How are you able to get bilateral cataract surgery approved? Many times my MDs are required to see the patient again prior to having the second eye done, which is usually scheduled weeks later.
So that's the beauty of the in-office suite. So we can't do them in the surgical center. In the in-office suite, we can basically do what we want. We usually eat the cost, like we get reimbursed half of the full cost of the cataract, the full reimbursement for the second eye, but for us, it's worth that pay reduction because it's so helpful for the patient. So if the doctor has an in-office suite, you can do bilateral same-day cataracts. If they don't, good luck.
There was a question, what do you consider stable refractive error and how young do you do LASIK on?
So it's indicated at 21. So anyone younger, you're going out of the FDA approval, but you can do it if they are stable. And stability is really a year without the refraction changing. Having said that, as Dan Reinstein says, like refractive instability is not a contraindication for LASIK, but you just have to understand that, let's say someone's a -6 and their refraction changing, but they just want to get back to kind of normal and get out of the Coke bottle glasses. You can perform refractive surgery. You just have to understand that things may change down the road. So if I have a patient with with a keratoconus, even who's had cross-linking, I'll still have the conversation that things may change, but we're getting you to a much better place, and then we can go from there. So if in 2 years you need to swap out that EVO lens or to have, because you can do a small amount of corneal surgery on if it's mild form Frust or PRK in a keratoconic. I'm hesitant to do that, but you can if it's a much smaller correction. But I would lean towards swapping out that EVO if things shift. But just having the conversation with the patient, if it's a moving target, but they're motivated, it's just a starting point.
Can you add EVO over top of previous cataract surgery? Say they had a PCIOL.
I wouldn't. You don't. I'm not sure what the rationale would be if you miss the mark or the target with the lens. So the point of the cataract surgery is to correct the patient's error. So let's say you're aiming for plano. If you miss that and you're a -0.5 diopter, you have some residual astigmatism, I would just do a LASIK touch up or swap out that lens. There's not really a point to doing the EVO in that situation.
Are there any dilation restrictions with EVO, like in any cases?
Dilation restrictions. Oh, meaning can you not dilate the eye? No, there's a port,
Yeah.
so it's just a normal eyeball.
Great. Sorry, I'm trying to find this one. Can YAG laser for PCO affect the light adjustable IOL?
So that's a good question. Well, typically you should YAG prior to starting the treatment. So if the patient comes in 1 week and you see a PCO and it's affecting the refraction, I would YAG it before starting the treatments, just to clear off that opacity. If you pockmark the heck out of the lens and there's all sorts of divots and light scatter, that can give you aberrations. That's not ideal for anyone. Any lens, but yeah, I wouldn't muck up that lens. But a regular YAG laser, that's done well and with attention to not marking up the lens, it doesn't have any effect.
And do you recommend monovision LASIK or CLR for early to mid 50s?
So like we talked about, it depends if they have a PVD, they're much safer to do. It's much safer to do the CLR. LASIK is great for these patients because they do have a lot of accommodation reserve. The only issue is getting them to have real reading vision. So you can do monovision LASIK in the US. In the UK, they have Presbyon, which basically gives you extended depth of focus. It's super awesome. I almost don't even want to talk about it because it's so awesome. And we can't do it, which is super frustrating. But basically, it allows the distance eye to it's a LASIK procedure, but it creates aberrations in the cornea. So it allows a distance eye to see distance and up to -75. So it has intermediate vision, just as a distance eye. and then the near eye sees intermediate to near, and it sees fairly well at distance. So there's overlap. So basically the eyes are working together and they have the whole range of vision. So in Europe, I would probably favor doing presbyond over CLR for the younger patients in that medium range, in that presbyopia range. But in the US, if they have a PVD, and even if they don't, but you have a long conversation of retinal clearance with the patient, CLR has the better options for achieving true spectacle independence for presbyopia. So our hands are a little bit tied with the LASIK options. Monovision's fine, it's good. The problem is they lose stereo, and once you lose stereo, it's gone. You can't get it back, even if you reverse the monovision. So, you know, a lot of patients don't want to see distance one eye and even like a -0.5 in the other, and then their reading vision changes. So for me, I'm going to do a CLR because, or go to Europe for a presbyond. But I mean, the multifocals are amazing these days, and it's just, there's so many options. I would probably do, personally, a light adjustable with blended, because then you're using the aberrations and getting that same blend. But it's a good question.
I think we have time probably just for one more question. If you were to do combination refractive surgery, say LASIK and ICL for a high RX or cylinder power, how many weeks would you wait between procedures?
I would, oh, so you're saying if the EVO, so let's say I did an EVO and they had a -8 sill. Oh, can you guys still hear me? They had a -8 sill and we only corrected -6 of it. I would just wait till they're stable, usually about a month, recheck them, get the topography, and then you can go ahead and treat with LASIK the residual. But that's a great question. Stability is the key.
Great. Well, thank you so much, Dr. Shore, for this excellent presentation and all, answering all of these questions. There's actually many, many questions. So if you guys, you can email Dr. Shore or join us in the sponsor room. Maybe we can answer some of the questions there as well after this lecture. Thank you so much again, Dr. Shore, and make sure you guys join us for our next COPE approved event. Glaucoma Past, Present, and Future, Assimilating New Data About Diagnosis and Surgery in the Interventional Glaucoma Era. That's going to take place July 14th at 5:30 p.m. Pacific Time. Great. So again, this free CE presentation would not have been available without the sponsorship from Zeiss. So